I want to welcome us to this weekend tutorial, and today we'll be looking at a very important topic in the management of our patients in the ICU. So we are looking at airway management in the critically ill. All right, and this we're going to follow our learning outcomes. At the end, should be able to identify common clinical scenarios that necessitate airway care in the ICU. At the end, should be able to explain the steps involved in endotracheal intubation, tracheostomy, and front of neck access. We should be able to discuss the peculiarities of the use of laryngeal mask airways in the ICU. All right, we should also be able to identify the equipment used in airway management. We should be able to recognize and manage complications associated with airway management and implement strategies to prevent prolonged intubation by applying the SMART mnemonics. And lastly, we should be able to implement the GO strategies for readiness for extubation in the ICU. So these are our learning outcomes, and we'll go through that. So our outlines, we'll first of all present our clinical scenarios. I will go through this outline as we continue. Hopefully we should be able to conclude within the hour mark. Now, so let's look at these 4 clinical scenarios very briefly, and I want you to think about it as we go on in the course of the tutorial. So the first clinical scenario I want us to think about is a 45-year-old male patient with severe pneumonia leading to ARDS. Developed a rapidly worsening hypoxemia despite being on high flow oxygen therapy. Now he has respiratory fatigue and is unable to maintain adequate gas exchange. So you are the anesthetist or the intensivist on call. What are your immediate airway management options in this patient? I want you to justify your airway choice. So that's the first clinical scenario I want us to think about. The second patient is a 30-year-old female patient involved in MVA motor vehicle accident with a severe TBI and GCS of 8. So you're going to describe the risk this patient faces and how will you proceed with the care of this patient, all right, in terms of management, airway management, and all that. The third patient clinical scenario is a 75-year-old female patient with massive ischemic stroke resulting in loss of consciousness and inability to protect her airway. His airway, he was initially intubated for airway protection and mechanical ventilation due to altered mental status. After 2 weeks, the patient remains comatose with minimal improvement in neurological status. So the question is, what will be the next step in the management of this patient? Is there any bedside airway procedure you could do, and how will you perform it, and how will you, I want you to enumerate the benefits and the challenges associated with it. The fourth clinical scenario is that of a 38-year-old female patient in the ICU who developed anaphylactic reaction to an unknown medication that was administered during a routine wound dressing. They had generalized edema with airway edema, stridor, and severe respiratory distress despite administration of adrenaline. Attempts at reintubating these patients was difficult and could not be done due to progressive airway swelling. So the question is, what will be your, how will you approach this patient? All right, so those are the 4 clinical scenarios. Hopefully we should be able to discuss them at the end of the presentation. All right, airway management is critical. All right, in all critical care settings, be it in emergency, the operating room, more so in the intensive care unit. All right, it is the cornerstone for management of most of our patients. Studies have shown that about 25% of major airway events, vis-a-vis death, brain damage, requiring rescue, surgical airway, or prolonged ICU stay, is more likely to occur in the ICU. More than 25%. All right, so excellent airway management skills is a core requirement, therefore, for practitioners in any critical care setting, including the ICU. The slogan, lose the airway, lose the patient, is sacrosanct in the intensive care unit. So a good understanding of anatomy, physiological changes in the airway of the critically ill patient is key to prompt and effective airway management in these patients. All right, so let's remind ourselves of the anatomy of the airway. You can see the larynx, all right, and the trachea. That's what we're interested in right now. All right, you see the laryngeal prominence, the thyroid cartilage, the cricoid cartilage, and you see your tracheal rings. And this is important, especially when we get to the session on ultrasound, airway ultrasound in the ICU. So just to remind ourselves, and if you see my cursor, you can see the cricothyroid membrane. This is very important for our front of neck access. All right, so this is the posterior view of the airway, the larynx and the trachea, and the sagittal view. All of these are very important. It's where this hyoid bone is the posterior of the hyoid bone is important when you want to do airway assessment via ultrasound for post-extubation stridor, all right, or difficult laryngoscopy. All right, these are very important structures just to remind ourselves. So look at this. This is what you will see, or laryngoscopy. All right. So we'll see the glottic opening is here surrounded by the two vocal folds and the vestibular fold. All right. All your laryngeal cartilages are here. All right. This is the root of the tongue. All right. Posteriorly, this we will see. All right. I like telling people you see those two white structures, you are good to go. And sometimes when you cannot see anything, you can see the epiglottis. All right, it's good. It's a good sign that you might be able to secure the airway. All right, so this is the fiber optic view. All right, this glottis is closed. Okay, and it's very important for us to have this picture at the back of our mind as we manage patients' airway in the ICU. So what are the goals of airway management in the ICU? 4 P's. All right. You know, I like mnemonics. All right. So whatever we do, whatever airway management strategies we're employing, we want to always maintain an open and patent airway for the patient. All right. The airway should be adequate to facilitate gas exchange, especially for patients' respiratory failure. You want to protect the airway from aspiration for those patients with reduced level of consciousness. And the airway management is also key for positive pressure ventilation, either non-invasive or invasive. So these are very critical goals that we want to achieve in managing the airway in the ICU. All right, I need you to know that the airway management in ICU is different from any other setting. All right, it's unique, and there are 3 factors, 3 P's that make airway management in the ICU very unique. One, pathological factors, the illness or the injury that brought the patient to the ICU could make the airway very difficult in terms of anatomy. All right. Bernard and co-workers found out that the failure of 4 fast sources occurs in up to 30% of ICU admissions, ICU intubations, which is significantly higher in the operating room. So failure to successfully pass the endotracheal tube at first attempt, it occurs in about 30% of all intubations in the ICU. All right, the critical illness will also lead to unstable physiology with hemodynamic instability. All right, there are cases where at induction, even before the airway is secure, the patient could develop cardiac arrest because they are hemodynamically unstable. All right, many of them may have absolute or relative hypovolemia with thought space loss, and there's increased risk of cardiac impairment during that period of hypoxemia during laryngoscopy and intubation, and this could cause some cardiogenic shock from impaired myocardial contractility. All right, the second P, the patient factor itself. Most of the patients are hypoxic, they are obtunded, many of them are combative, or the three of them may occur in the ICU patient. So they do not give you the enough room to for hypoxia, to deal with hypoxia resulting from your laryngoscopy. It's been found that studies have shown that about 25% of patients in ICU, there are instances of severe hypoxemia with SpO2 of less than 80%. That is PO2 of about 70 millimeters of mercury. So even before intubation and during intubation, severe hypoxemia, all right, resulting from the patient factor could be there. Don't forget that most of the patients are not fasted, unlike your elective patients going for elective procedures, so they are not fasted, or some of them may have functional ileus. All right, all this leads to increased gastric content and regurgitation and aspiration of gastric contents. Peculiar factors, unlike in the OR, the ICU is not a controlled environment for airway care. All right, it is something that needs to be looked at. All right, the ICU is not designed primarily for airway management, unlike one of the examples is that most of all our operating room tables, they are T-table. All right, most of the ICU beds are not. All right, and that is critical for airway management. Monitors and a lot of equipment. It said that every patient space should be about 25 square meters. All right, the presence of monitors, equipment, and all that can limit access to the patient. I personally observed where colleagues are trying to assess the airway and they are standing by the patient's side instead of by the patient's head because of limited access to the patient. Lack of skilled assistance during odd hours. All right, lack of advanced airway equipment. A lot of times the ICU is not prioritized for advanced airway equipment, and some of the things we're going to talk about is the need to have video laryngoscopes and fiber optic bronchoscope in the ICU, but most of the times the ICU is not prioritized. And now the American standard is coming to Africa, where we have non-anesthetics who are now trying to run the ICU. And most of these intensivists who, with no anesthetic background, lack basic formal airway training. And all this make the ICU environment very unique in terms of airway care. All right, so now this is the table to just elucidate all the things I've been talking about. So ICU related factors, infrastructure, equipment, timing, patient factors. All right, we're going to look at them. Most of the times we do not have time to do proper airway assessment. Risk of aspiration, challenging anatomy. All right, inefficient pre-oxygenation, patients desaturate fast because of the pathology, hemodynamic instability, and these are the things I've mentioned before. Operator factors. All right, most of the times we don't have skilled hands during odd hours in the ICU. Okay, so we're going to go into endotracheal intubation, all right, in the ICU. Sometimes most of our patients come intubated, but sometimes we need to intubate, all right? So it's been found out that endotracheal intubation is one of the commonly performed airway procedures in the ICU, all right? And that means that every practitioner needs to be skilled at it. Whether you have anesthesia background or not, it should be a core competence that should be required of all intensivists. Indications of endotracheal intubation in the ICU include pulmonary gas exchange following respiratory failure, or it could be hypoxemic or hypercapnic. Protection of the airway, all right, patients with upper GI bleeding, patients with vomiting, all right, decreased level of consciousness, neurological impairment. All these patients need the protection of the airway and require intubation in the ICU. Patients who have suffered cardiac arrest, you want to secure the airway, all right, during cardiopulmonary resuscitation and even after for post cardiac arrest care. Post-surgical procedures, all right, they require post-op ventilation, and therefore you require to secure the airway, patent airway, all right, patients who have polytrauma and all that, you want to secure the airway. So these are some of the indications for endotracheal intubation in the ICU. All right, so there's a stepwise, just like, okay, let's just go into this. So the first thing you want to do is airway assessment, and this is critical, be it in the OR, be it in the emergency room, and also in the ICU. But like I mentioned before, a full airway assessment may not be practicable in the ICU, and this leads your patient to unanticipated difficult airway, and this may lead to loss of the airway and loss of the patient. There are a lot of patients that have died from failure to secure the airway from poor pre-procedure airway assessment. Now, nasal oxygenation has been found. Studies have shown that it can help to facilitate pre-oxygenation while you also do your airway assessment. Put in mind when you're doing that, not just the airway, put in mind patient's record. I remember some years ago, there was this patient that was managed in our ICU, came in intubated, but we didn't get a history that the airway was difficult. In the OR, it was a post-surgical patient, and we attempted extubation after some time, but the patient desaturated, became very distressed, and we attempted to reintubate this patient. It was practically difficult in a very unfamiliar, unfriendly ICU environment. We lost the patient's airway because there was failure to know the patient's record. It was afterwards that we were told that it was a difficult airway in the OR. So patient's record is very important for us to assess patient's body habitus, handover details, especially patients who are sedated or uncooperative. Another thing is that one of the assessment you need to do is hemodynamic optimization. All right, even as part of your assessment, hemodynamic optimization has been found to improve outcome, and there's this validated score that has been used especially for airway assessment in ICU. It's called the Makocha score. The Makocha score. All right, the Makocha score is a list of items that we can assess. One of them is malampathy. All right, so Makocha score that is greater or equal to 3 is a predictor of difficult intubation in the ICU. So a lot of times we're told that malampathy, the patient must sit up, open the mouth maximally without phonating so that you can assess the perioral airway structure. But studies have shown that it's valid even in supine patients, especially patients who are cooperative and voluntary. Even in supine, malampathy grading can be done. So patients with apnea, AM stands for malampathy class 3 or 4. Patients with apnea syndrome, obstruction, patients with cervical spine limitation, spinal cord injury, patients with limited mouth opening less than 3 centimeters, cannot take 2 fingers, patients who are comatose, patients who already are hypoxic, all right? And when you have the operator, all right, whether anesthetists or non-anesthetists are not trained. So you do this score for all your patients, and a Makocha score of greater than or equal to 3 is a predictor of difficult intubation. All right, this is it here. All right, so malampathy score 3 or 4, you give the patient a 0.5, 5 points. Patient with obstructive sleep apnea syndrome or apnea syndrome, you give the patient 2. Patient with reduced mobility 1, limited mouth opening 1. All right, patients who are in coma 1, severe hypoxemia, SpO2 of less than 80%, you give the patient 1. If the Operator is a non-anesthesiologist or not trained, you give the patient 1. So the total score is 12, all right? But any score 3 or more is a predictor of difficult airway. All right, so airway equipment is very important here. Like I mentioned before, infrastructure. Yeah, the ICU is not prioritized in terms of provision of airway equipment. And that's why I created this mnemonic, less is bad. All right, when you have less airway equipment, it's a bad omen for your patient. So if I meet you in an exam and I ask you, list all the equipment, especially the very significant equipment for airway in the ICU, just write less is bad, and you'll fill in the other gap. So laryngoscope, all right, direct or video laryngoscope with appropriate blade size, all right, is crucial, all right, for airway, management in the ICU. Different endotracheal tubes, appropriate size, like we're taught in anesthesia. You want to get the appropriate size, then one above and one below. All right, stylet to guide the ETT. Don't forget that you do not have a controlled environment, so you need a stylet suction device. This patient, most of them have secretions, and you want to be able to have a suction device to clear and improve visibility. Back valve mask is important, all right, for pre-oxygenation and ventilation when needed. You must be able to monitor your patient continuously. Devices for monitoring, your pulse oximeter, capnograph, and ECG monitor. Unfortunately, many ICUs do not have provision for capnograph. Your drugs, different kind of drugs. The drugs you're going to use depends on the patient's hemodynamic stability. All right, so you should have a good armamentarium of your sedatives, either propofol, ketamine, or even opioid-based. All right, muscle relaxants, suzametonium and rocuronium. So less is bad. All right, Reynolds and Co. Divide these white back people, okay, as their own mnemonics, but my mnemonics is less is bad. So if I meet an exam, you give me my mnemonics, all right? But for the sake of having a broader perspective, white back people. So you have your Yanka suction, back mask. You want to assess vein, get your team, position your patient, get a endotracheal tube. You must be able to have the provision for oxygenation, pharmacy, laryngoscope, evaluate. You agree with me that mine is better. So less is bad is the equipment you should use. So you must have different plans, like the Difficult Airway Society, or also had made out an algorithm for airway management in the ICU, just like in the OR, but there's with some slight differences. So your plan A, you also prepare, oxygenate, induce, mass ventilate your patient, and then successfully intubate. That is plan A. All right. So position is very important, except in patients that have limited mobility. All right. And we're going to look at different ways to assess such airway. So you want to position your patient with what they call the sniffing position, sniffing the money air position. And for obese patients, you want to ramp them, put pillows behind their chest, and make sure that the tragus of their air is in same alignment with the cricoid cartilage, that is ramping. All right, pre-oxygenation, the traditional back valve ventilation can be done, but it's been found out that patients who are pre-oxygenated via the ventilator, all right, has better oxygenation index. All right, so if your patient is already on ventilator, just put it on non-invasive mode and use your CPAP of 5 to 10 centimeter, all right, or you can use your pressure support breaths, about 7 to 10 milligram per kg, all right. It's been found that it's better than back valve ventilation, apart from the fact that it has increased risk of regurgitation, all right. With back valve mass ventilation, your non-invasive ventilation, all right, with CPAP 5 to 10 centimeter, your pressure support breath, all right, which about 7 to 10 mil per kg, has been found to have a better oxygenation than back-based ventilation. All right, so procedure. Remember that these patients, let me see, there's a comment here. Let me see if there's no audio, it's just me. Can you hear me? Somebody said there's no audio. Can you hear me?
Yes, Prof,
Yes,
I can hear you, sir.
Yes, Prof, we can hear you.
This person said there's no
Yes, sir,
audio.
we can hear you, sir.
All
Yes,
right.
we can hear you.
We can hear you, sir.
Okay.
Probably
Yes,
it is from his end.
Okay. I was scared that I've been talking for the past few minutes. All right. So the second procedure, remember that every patient in ICU should be taken as fasted patients. So you want to do rapid sequence induction, all right? And the goal is to prevent, aspiration, all right? But there are ways to reduce the risk of aspiration. You want to temporarily discontinue enteral feeding, all right? You want to suction your NG tube, all right? And crack cords a Selig maneuver by a trained assistant. There have been a lot of discussion about direct laryngoscopy and video laryngoscope. If I have the power, every ICU should have a video laryngoscope, all right, because it gives you, a real-time visualization of the airway, a real-time optimization of your crack-up pressure, and you do not need to, extend and position a patient in this even the Montpellier position. So video laryngoscope must always be in the ICU. All right, proper drug selection is key, all right, for successful intubation in this patient. So your induction agent, remember, like I mentioned, your hemodynamic stability of your patient status is very important. The issue of muscle relaxant, SOSA versus rocuronium. Don't forget that SOSA has a lot of complications, side effects that you do not want in your patient. Some of our patients have electrolyte derangement, and SOSA-induced hyperkalemia may be detrimental to your patient. And the advantages of rocuronium include that it has similar intubating conditions to SOSA, and it can also be antagonized, all right, by your pre-calculated dose of sugar mothers. I don't know how many of our centers have rocuronium, but we have used this and it's very good, all right, especially if you have sugar mothers in your tray. Now, one of the things we must always do is that always have a vasopressor ready, all right, during intubation, because this patient may collapse. So you have part of the Montpellier intubation bundle we're going to see very soon is adequate. Some people say that you can actually do fluid bolusing, all right, in anticipation of hemodynamic changes, but having a vasopressor, adrenaline or non-adrenaline, is a must, especially when you're intubating your patient in the ICU. All right. Okay. All right. So I just mentioned video laryngoscope. All right. Policymakers, we need to make noise. We need to demand for this. All right. There are almost about 10 or 8 advantages of having a video laryngoscope, a functioning video laryngoscope. One of the things I want to drive home in this tutorial is for us to see the need to have a video laryngoscope in our ICU. One, it reduces the stress of the operator during intubation. All right, you can use it to diagnose and record airway lesions, abnormal anatomy, and pathology. You can use it to pass your transesophageal probes. You can use it to pass your NG tube, double lumen, and all that. All right, you can even be used for your video assisted fiber optic intubation. Okay, it helps the trained operator to apply your laryngeal manipulation, the backward, upward, rightward pressure, the bob maneuver. With your video laryngoscope, you can instruct your trained assistants to apply bob. Awake intubation, especially in abdominal intubating position, your patients who are in lateral decubitus position, the video laryngoscope comes handy. All right, and another advantage is that it's less traumatic than the ordinary laryngoscope, and it reduces the cervical mobility in patients with unstable C-spine and reduced spinal mobility. So video laryngoscope is a must as part of the equipment that is needed in the ICU, especially for airway management. Remember my mnemonic, less is bad. All right, there are different types of video laryngoscope. I just brought it here. I don't know how many of us have it in our centers, but please, it's very good. All right. So some of the disadvantages that it requires a learning curve. All right. You need to learn it. All right. Training is important. Sometimes it may be difficult to pass the tube, despite the fact that you are seeing a satisfying laryngeal view, but passing the tube may be difficult. You lose the depth perception, fogging, and secretion can actually obstruct the camera. Hey, in our environment, resource limited environment, the cost may be prohibitory, about 5,000 to 10,000 pounds. All right, but it is something that we can advocate for, ask donor agent and prioritize the need for it, especially when we consider the advantages of video laryngoscope. All right, so the other way to secure the airway in the ICU, and don't forget the reason why airway management is unique in the ICU, all right, is the flexible scope intubation, your fiber optic. All right, now it's indicated in places where placement of your NT tube is ETT is in anticipated difficult airway. All right, you can actually use it to confirm correct placement of your endotracheal tube. All right, it can also be used for the minor abnormal anatomy, obstructive upper airway. All right, very, very good and very handy in airway management of patients with unstable C-spine. Evaluation of airway obstruction, and you can use it to evaluate the airway prior to intubation for patients with known abnormal anatomy. All right, so flexible scope intubation is important and is one of the skills that every critical care practitioner must have. All right, so this is it. I borrowed this. The source is Orlando RH Michael. All right, Honks difficult fairway. All right, they hold the copyright. I don't, so I put the source here. All right, so you need to load your ETT to the fiber optic scope or your bronchoscope. You want to suction before the insertion of your scope. Apply a bite blocker or a fiber optic plastic airway. Maintain midline until you are able to see a satisfactory view. All right. Now, NASA intubation avoids the gag reflex associated with orogastric intubation. Oral intubation, orotracheal intubation. However, the chances of epistaxis is high. So if you want to use the NASA route, make sure you give your topical NASA decongestant like your oxymetallazine and your 1% phenylephrine to decrease NASA bleeding. Awake intubation can be done with your fiber optic scope, all right? But sometimes you may need to give your patient some degree of sedatives. Daniel, please, can you mute yourself so that we have one house? Thank you. All right, mute all. Okay, sorry, I'm trying to just mute. All right, so that is your flexible scope intubation technique. All right, so the Montpellier ICU intubation algorithm. All right, so this is the algorithm. Don't forget that bundles and algorithm helps to prevent unwanted complications. So pre-intubation, there must be presence of two operators. All right, that's the Montpellier ICU intubation algorithm. Fluid loading. In the absence of cardiogenic edema, fluid loading, preemptive fluid loading. You want to also prepare for long-term sedation, all right, for your patients. The indication for the intubation may require long-term sedation, so you want to get your sedation depends on your local protocol, all right? You can use your midazolam, opioid-based, or whatever you want to use. Pre-oxygenate for 3 minutes with FiO2 of 100%. All right, like I mentioned, you can use your bag valve mask or you can use your non-invasive technique with your monitor, with your ventilator. Rapid sequence induction. But if you are using ketamine, it's no longer rapid sequence, modified rapid sequence. Rocuronium, like I mentioned before, I'm just going through the algorithm for us to know that there's an algorithm, and if possible, every ICU should print out this Montpellier ICU intubation algorithm and paste somewhere conspicuous in the ICU. So anytime we want to attempt at intubating a patient, it must be there. Everybody must go through it. All right. Post intubation, you want to confirm correct placement with capnography. All right. If your diastolic blood pressure goes down below 35 millimeters of mercury, you want to give your norepinephrine, initiate your long-term sedation that you have prepared. All right. And you want to connect your patient to mechanical ventilator with lung protective ventilation, tidal volume of between 6 to 8 ml per kg. Reset your ventilator requirement. Recruitment maneuver, all right, must be started, especially if there are no cardiovascular collapse. Initially, you want to set your FR to 100, but within 2 hours after you obtain your ABG, if your PO2 is satisfactory, gradually reduce your FiO2 to a satisfactory SpO2 or PaO2. Maintain your intubation curve between 25 to 30. I don't know how many of us have the airway manometer, all right? It's usually connected to your tube at intubation, and that's what you use to inflate the cuff of your tube so that you can be objective in getting your cuff pressure between 25 and 30 centimeters of water. Post intubation, yeah, this is Toby's mnemonics, IPACO, all right, IPACO, all right, confirmation of correct tube placement. God help you if I meet you in exam and I ask you how will you confirm correct placement, and you do not give me IPACO, I will not smile with you. All right. So IPACO, you want to expect for misting. All right. That is the shows that carbon dioxide is coming out. And you want to also inspect your ETT pass through the vocal cords. So inspection, that is the I. P, you want to palpate. A lot of times when I'm present and somebody is intubating, before I even reach out to the stethoscope to auscultate, my hands on the chest. I'm palpating for bilateral chest expansion. Auscultate for bilateral breath sounds. Chest X-ray. This is mandatory. Post intubation, obtain a chest X-ray. The advantages are many. You can see the tip of your endotracheal tube above the carina. You can also use it to check for correct placement of your central line and even the lung pathology. So immediately after intubating, obtain a chest X-ray. Capnography for sustained ETCO2 waveform and ultrasound. I hope we have time. We're going to talk a little about ultrasound of the airway. Ultrasound can be used to confirm correct placement in the ICU. All right, what are the complications? All right, complications of endotracheal intubations are many. All right, I put hate peace. All right, I hate it. Hypoxemia, especially following prolonged intubation attempts. Like we mentioned before, studies have shown that about 30% of cases there is loss of first pass. All right, a lot of times more than 30% of patients we do not pass our endotracheal tube at first attempt. So the prolonged intubation attempts or inadequate oxygenation may lead to hypoxemia. All right, aspiration of gastric contents during the procedure, trauma, all right, to the teeth, lips, vocal cords, and trachea. You can have esophageal intubation, all right, and you can use your ultrasound actually to check that. I really want us to get to that point because it's something I'm excited about. All right, pneumothorax could be resolved from barotrauma or trauma during intubation. Hemodynamic instability, like we mentioned. Late complications of endotracheal intubation include ventilator-associated pneumonia, tracheal stenosis, and there was a study we published in 2017. 2007 or 2017 now. I'll show you where we had 2017, yes. All right, when we had, let me see. All right, Okay, I'm going to come back to that. Okay, so laryngeal injury causing vocal cord paralysis or glaucoma formation. These are some of the complications of your endotracheal tube. This algorithm, tracheal intubation of critically adults. All right, the pediatric one is also available, but just go through it once you get the lectures, or you can actually Google for it. All right, it is a good algorithm for you, step by step. Have plan A, plan B, plan C, and plan D, and hopefully we should be able to talk about front of neck access in this presentation. I think I have 15 minutes more. What do we do? So now, after the patient has been intubated or tracheostomized, the care of the intubated patient is key. I remember an experience some time ago, some years ago, where during nursing care, there was accidental extubation. And what the nurse did was to just put the tube there back. All right, obviously it went into the esophagus. All right, and there are other cases where we have secretions, thick secretion causing airway obstruction, patient developing apausia, patient becoming, coming down to cardiac arrest. So after successful intubation, we must follow the proper care of the intubated, tracheostomized patient. Now, studies have shown that the most hazardous phase of airway management in the ICU is after the initial airway management. Ironic, isn't it? All right, the patient has been successfully intubated, but the patient is not out of the woods yet. It's been found out that over 80% in a British study, about 80% of airway-related critical incidents occurred after the initial intubation, and 30 of them were major airway events. All right, this was published in the UK National Patient Safety Agency in Anesthesia, 2009. So over 80% of airway-related critical events occurred after the initial successful intubation. So what do you do? How do you care for the intubated patient? Number one, document the depth of your endotracheal tube. Like I tell the nurses I work with, make it part of your vital sign every day. All right? Patient intubated and secured at 22, 24, 21. It must be documented. The reason is because every day, if for the intubation confirmation of correct placement, and it was at depth of 22, and the next day is now at 18 or at 24, 26, something has gone wrong with that tube. All right, it calls for critical appraisal. All right, secure your tube. Very, very important. Cuff pressure. All right, always maintaining, some people say 25 to 30. All right, so maintain your cuff pressure. Make sure you have your capnograph. All right, I don't know how many of us, like I mentioned, have capnograph. Humidification, all right, to reduce secretions and becoming thick and tenacious. Suction your oropharynx regularly, and more importantly, maintain this patient at 35 degrees. There's a slide where I talked about specifically managing airway secretions in the ICU. Secretions are terrible. They are the enemy of progress in our patients. So there's a slide that where I talked about how to manage secretions effectively in the ICU. All right. Okay, oh, it's here. So it's here. It's the next slide. So managing airway secretions in the ICU, suctioning. All right, open suctioning or closed loop suctioning. I'm an advocate of closed loop suctioning because you do not need to disconnect your endotracheal tube or your tracheostomy tube. The inline is called inline suctioning or closed loop suctioning is important, is connected to the ETT or tracheostomy tube, and all you need to do is to open and close the valve and you suction your patient. It reduces the risk of infection and all that. It's actually part of the ventilator-associated pneumonia prevention bundle. Humidification, either active or passive. All right. Hydration, you want to maintain adequate IV fluid. and enteral feeding. Mucolytics like your acetylcysteine or hypertonic saline. All right, and I've used what's it called, bicarbonate before. All right, to dissolve secretions, these secretions. Bronchodilators open the airways and they can help you to clear your secretions, especially in patients with reactive airway disease, COPD, and asthma. Chest physio can either be manual, we should be able to cuff our hands around the patient and start caudal and go cephala, and you are able to mobilize secretions from deep down, and you're able to suction it. There are mechanical devices, all right, with that helps, all right, to mobilize secretions from the patient. Okay. There's this chest vibrator that we've seen, I've used before. It's very good, all right, and it helps to mobilize secretions, all right, from the distal part, and you're able to suction it. All right, positioning. There are issues. Do we keep the patient supine or labor position? Sometimes, especially if you have a patient, and those of us that are in theater, you have a patient that you just finished surgery, and the patient is, vomiting. You want to place the patient in the labor position. It helps you to clear the vomiters or the gastric content. Even patient who had tonsillectomy, like what we call the tonsillar position, you want to put the patient head down and tilt the patient to the left. It helps with secretions clearance. Cough assist techniques, either manually, you help the patient to cover, and bronchoscopy. There are instances where we've called the bronchospists. What they call them now, those guys, those respiratory guys, that do bronchoscopy, all right, to assess for secretions and help to clear the secretions. So these are some of the ways to manage secretions in the airway. Now, there are airway red flags. This is adopted from the McGrath BA National Tracheostomy Safety Project. Your patient is intubated or tracheostomized. There are red flags, but when you see them, it tells you there's something wrong with this patient. Oh my, I have 8 minutes. I hope we'll be able to go through this. Okay, let's see. All right, so when there's absence or change of your capnograph waveform and the patient is being ventilated, there's an airway problem. All right, when there's absence or change of chest wall movement with ventilation, all right, increasing airway pressure, reducing tidal volume, inability to pass a suction catheter freely, when you have obvious air leak, when the patient is able to vocalize with the tube placed and inflated, when there is apparent deflation or need for regular reinflation of the pilot balloon, when there is a discrepancy between the actual and recorded tube insertion depth. You see the reason why it's important for you to document the insertion depth of your tube, or you have surgical emphysema. These are airway red flags that will call for immediate attention. All right, prolonged intubation. This is one of the sequelae of endotracheal intubation in the ICU. All right, so it's defined variously, depends on the definition. Some people say 7 after 7, some people say 14 days. All right, we did a study in Benin, University of Benin Teaching Hospital, that was published in 2017, like I was saying. One of the complications, subglottic stenosis following prolonged endotracheal intubation in the intensive care unit. So prolonged intubation may be necessary sometimes due to severe respiratory failure, inability to wean your patient off ventilator, and all that. All patients have impaired neurological function. All right, your GPS patients may require prolonged intubation, but be aware of the complications associated with the tracheal injury, stenosis, granulation tissue formation, increased risk of your ventilator-associated pneumonia, and difficulty with weaning this patient from ventilator. All right, so be smart. All right, the way to prevent prolonged intubation is for you to be smart. All right, I tell people the day you intubate your patient and put your patient on ventilator, that is the day you start weaning them off. All right, so be smart. X, sedation vacation. All right, every day. Apart from traumatic brain injured patient that I want intubated and sedated for the first 24, 48 hours, every other patient on a daily basis should have sedation vacation. This to allow you to assess neurological function and also to assess for readiness to wean from ventilation. M stands for mobilization. All right, passive and active range of motion exercises. This helps to improve muscle strength and reduce critical care, critical care, critical illness associated polyneuropathy. All right. A lot of times, the reason why patients stay long on ventilator and prolonged intubation is because of critical illness associated polyneuropathy. All right, or also known as ICU acquired weaknesses. Daily assessment. Daily assessment for spontaneous breathing trials to evaluate the patient's ability to breathe on his or her own. Respiratory techniques optimization. All right, I put nutrition here. Adequate nutritional support helps to prevent muscle wasting, ketosis, and support respiratory muscle function. Tracheostomy, early tracheostomy. This also has different definitions, all right? Some people talk about early tracheostomy, late tracheostomy, but early tracheostomy in patients who are expected, all right, to require prolonged mechanical ventilation may help improve comfort and facilitate weaning. So these are the smart strategies on how to prevent prolonged endotracheal intubation. Extubation criteria, this is my ghost criteria, all right? All right, so the SMART is also original and the ghost criteria is also original. This is an adaptation. Those of you who have worked with me, this is an adaptation of readiness to wean from ventilator. So I call it ghost criteria. G, gag reflex, the patient, before you want to extubate your patient, all right, you want to ensure that the patient has an intact gag reflex with a GCS of at least 10T over 15. The patient must be hemodynamically stable or requiring little or no vasoactive support. The patient should be able to maintain adequate oxygenation with your PF ratio greater than 2. 200 is small for me, but the book said 200. I would like a PF ratio above 250, all right? And there's no need for supplemental oxygen. Patient is breathing spontaneously, all right, and require little or no support from the ventilator. Tracheal secretions, the patient should be able to manage his or her tracheal secretions effectively, which includes coughing and clearing them out without difficulty. I think we'll stop here. Our time is fast spent, it's more than 1 hour. We still have tracheostomy. It's long. Complications, we have cricothyrotomy in ICU. Oh my, supraglottic airway in ICU, ultrasound in airway. Yes, I think we'll stop and we'll go over our clinical scenarios. Hopefully, maybe next week we'll continue with airway management because it's already past, it's almost 9 o'clock, and I want us to discuss our clinical scenario. All right, can we vote on it? We should stop here. And next week we continue with tracheostomy. Airway management is a big one. Do we all agree?
Yes, Prof.
Yes, sir.
Yes, yes, I
Yes,
agree.
Prophet.
I'll
Yes,
stop
Prof.
here, sir.
Okay. Yeah, I think we
Yes,
should
sir.
stop here. Then next week we'll continue with the other airway management. I didn't know it was this so much. Okay. So let me stop.